Good evening, viewers. Welcome to Sukino Health Capsules. As we know, every time we have a distinguished person with us who will talk about his specialty and the work experience that he's had in his field, the challenges, and of course some interesting facts. So today we have Dr. Srinivas Reddy with us. He's a neurosurgeon practicing at Fortis Hospitals in Bangalore Road. He hails from Anandpur in Andhra Pradesh. He has also finished his undergraduation from Government Medical College in Anandpur. Following that, I think he's had his training at Fortis Hospitals as a neurosurgical trainee in the National Board of Examinations, and he has graduated in 2020. And currently he is working as the associate neurosurgeon in Fortis Hospitals itself. So we'd like to welcome Dr. Reddy here. Thank you so much for sparing your valuable time, and I'm sure our viewers are going to be very happy having you here, and we have a few questions. So what made you really interested in neurosurgery? What made you?
So first of all, I would like to thank you for this opportunity, providing me, inviting me here to speak about my specialty and about myself. So, and yeah, the first question of yours, so what made me interesting towards the neurosurgery? So when I was doing my undergraduation in the Government Medical College, so where I finished my MBBS and then started my internship. So where that is the beginning phase of a doctor's life. So there we used to see a lot of head injuries coming to the hospital and then being referred to the higher center, not even addressing to the patient, not the conveying. There is no facilities for any surgical procedures that can be done in the brain or the spine during that time. So that was the first time when I realized why nobody is taking the patient for the care here. So then I realized I had to think about this, and then I thought about, and then I went on to pursue this neurosurgery, and then now I became as a neurosurgeon, so practicing in Bangalore. And then yes, I'm going to my hometown to started my OPD services there. So probably down the lane I may operate there itself, so providing the services there.
That's very good to know, because I'm sure the other people in the rural areas also don't have access to this kind of neurosurgery practices.
Yes. Yeah. So the surgeries in the brain and the spine, being a complex, the most complex and a beautiful organ to operate is the brain, and then the next thing comes to the spine. So anything irreversibly damaged, then it cannot be restored. So that is the reason the technique, the skill, and then the equipment, latest technology, everything matters for the surgeries in the brain and the spine.
What are the challenges that you face when you're doing in something like a rural area or a tier 2 or a tier 3 state?
Yeah. So apart from the metro cities where we can get everything under a single roof, so then we can use this magnifications, illumination, and then special dyes for the tumor surgeries, all these things. But if you go back to the rural services or the tier 2 or tier 1 cities or the towns, so they not even a microscope or a surgical loop for the magnification, they will not. It may not be available. So considering that, the incisions will be bigger, and then the surgeries will be longer duration, and the risks of infections, blood loss will be more, and then the risk of developing post-operative new deficits for the patients will significantly increase, which results in the increase in the morbidity and the mortality. So which causes a financial stress on the family because of the new deficit. If the patient cannot move post-surgery, then if he is the sole breadwinner for the family, then yes, the family will be under so much of constraint for the finances, all these things. So that will increase still burden on the society. So my thought process will be, if the government can provide the magnification devices like the operating microscope in the tier 2 cities, that will enhance the surgical skill and the procedures.
Okay, thank you. So I'm sure our viewers would also like to know, what are your key areas of interest, in the sense there's brain, there's the spine, there's minimal invasive surgery. What is it that you see yourself, is there that you would like to specialize in a particular area, or would you like to?
So I would like, I'll love to operate on the spine and majority of the cases which I operated are the spine related. And then I had the exposure for the cranial surgeries also, but my tilt is towards the spine. Operating the spine, I feel more comfortable. And then progressing towards every surgeon has to learn something every day till he stops operating or till his breath is lost.
That's true.
So the surgeon or a doctor, in fact, so they are the students for life, and then we have to learn everything new every day from every patient, and not a single surgery can be repetition. So every surgery is different, and we have to take every case as a single case, and then we have to give the best for the patient, and then have to progress towards the minimal invasive surgeries now on the spine, so which has a lot of scope and demand in the future. And the patients are also tilting towards the smaller incisions and then maximum benefits.
Okay. So I'm sure everybody here would like to know what are the most common complications that you see in neurosurgical patients that you've operated on. What are the kind of risks that are involved in these?
So the most common complications which we accept or which we see in the surgeries related to the brain and the spine, or a patient developing any weakness. So that can be minimized with the help of magnifications like operating microscope and then special dyes while operating the tumors in the brain or the spinal cord, and then use of the proper technique and the skill. So when we are operating on the brain tumors can be originating from the brain parenchyma itself and brain substance itself, or the other kind of tumors which will originate outside the brain, and then it will push the brain into the in the skull, so increasing the pressure inside the skull. So these two are different kinds of tumors, and then the tumors which originate outside, that can be operated very safely without damaging the brain at all. So if we keep the plane of the coverings around the brain intact, then the patient will not have the deficit. So if on the other hand, the tumors which originates from the brain substance itself, so we have to choose the entry point into the brain substance which will give the least deficit to the patient or no deficit. So that way we should plan accordingly. Every patient preoperatively, we have to see all the scans, we have to study the patient in detail, and then we have to plan for the surgery.
So there must be a lot of fear in the patients who approach you. Like obviously they've got a medical condition which needs an operative intervention, and then they come to you. What are the things? I mean, how do you really counsel and allay their fears before taking them up for surgery? Because I'm sure there's a lot of anxiety related to these conditions.
Yeah. So especially these kind of situations we face when a patient is relatively young or just started working, or in the sole breadwinner of the patient family. So yes, their questions will be very logical, very legally issues also.
Yes.
So they will ask, so I don't drink, I don't smoke, I am well educated, I am working in a very good company, and I am extremely intelligent, and I am working in a US, then why me? So for this kind of questions, yes, even we don't have the answer. It's our fate which is decided from the God. So whatever is the problem, that can be addressed, and then we can give the best solution for the patient to sustain the extent. If it is a malignant brain tumor, yes, so then we can we can give the best of the surgery and then the rest of the treatment for the tumors, and then we can see how the natural progress it will take care. So from the counseling point of view, preoperatively, yes, we will tell, including all the complications, risks, everything to the patient, but we will make sure the patient is comfortable, and then they can speak with the old patients of ours who underwent similar kind of surgeries, and then they can take a call where to get operated.
So talking of risks, I mean, what would be the steps, safe surgical practices to, kind of mitigate the risks that are associated with all surgeries, of course, but specifically more with neurosurgical cases? What are the things that you kind of incorporate or, convey to your patients that these are the things that you do to make the surgery as safe as possible? Of course, given all the complications stay, and those are explained obviously, but then what are those practices and things that you use in your...
Okay. So usually in our practice, we do admit any patient 1 day prior to the surgery to get complete health checkup done. So including from the blood counts, including his heart and chest, everything, lungs, everything will be checked, and then the pre-anesthetic evaluation will be done properly and thoroughly, and then all the seniors, anesthetists, senior surgeons, everybody will speak with the patient, and then they will give the motivation for the patient so that the patient should not be depressed and anxious about the surgery or his outcomes after the surgery. So if the patient gets admitted 1 day prior, then all the things will be sorted out. Psychological counseling also will be there, one session, and then we will assure that the patient should not have any further complications during the surgery, and there should not be any issues during post-surgery. So 1 day post-surgery, yes, definitely the patient will stay in the neurosurgical ICU, where we will have the extremely trained nurses and the staff who will address the patient immediately if there is any issue cropping up.
Any cases where you've had to take a decision that, okay, maybe we need not operate for this case, or we delay the operation, or how do you arrive at that decision? Are there cases like that where it's really kind of helped you work your way through these kind of cases and kind of delayed certain things, or or you had to take an instant decision, no, we'll take them up immediately?
Okay, so there are certain situations where we will have a diagnostic dilemmas. So whether to operate, if we have to operate, when to operate, and if we have to stop the surgery, when to stop. So if these are the situations, these are the questions, first thing is I can tell you by an example. So right now we have a patient in the Fortis hospital under a nephrology team, where the patient got admitted with a large clot in the brain. So still the patient is conscious, and then patient had issues with the renal dysfunction, where he has severe acidosis, which is definitely not acceptable for any surviving patient. So the parameters has to be corrected before we take up for surgery. So apart from that, if we rush the patient for the surgery, the patient may not come out of the anesthetic drugs or the anesthetic effects, and the patient will stay for longer time in the hospital and in the ICU, which again, yes, will increase the cost of the surgeries and cost of the hospital stay. So now the parameters has been corrected, and yes, tomorrow we are planning for the surgery for him.
Okay.
That is one scenario. And the other scenario is if a young patient with a huge clot after the trauma or any hypertensive bleed, young patients nowadays we are seeing probably because of the stress or whatever is the reason. So the blood pressures are not being checked properly and regularly. So that is causing an increased blood pressure and then bleeding inside the brain. And they will be rushed to the emergencies where we have to take a call whether to operate or not. So depending on the pre-operative neurological status of the patient, yes, then we have to rush the patient either for the surgery or no surgery. So if you have to decide for the surgery, yes, the patient has to be operated as early as possible, ASAP. Or if the patient and the family doesn't want any surgery based on the pure neurological outcome, because it's an emergency, yes, patient will have a lot of neurological deficit and he may not improve completely and he may not get back to the normal life. Or if the patient's neurological status itself is very low, that it is not associated for his survival, then yes, we will counsel the family that both with surgery and without surgery, what will be the benefits, and with surgery, how much he can improve, what are the possibilities for his improvement to back to his independent life. Then based on that, the family decision, we have to respect the family. Even if the family wants the surgeries, all these things, then yes, we will go ahead. Otherwise, we will discourage the surgeries at that point.
These are important decisions to be made at that point. At Sukino, we do get a considerable number of patients who are stroke patients.
Yes.
Neurosurgery and stroke, what do you have to say about that?
Yeah, so the stroke, it involves smaller vessels or larger vessels. Yes, smaller visual strokes can be managed with the medications and the good physiotherapy, where the rehab centers like Sukino will come into the picture. And then larger visual strokes, so if the half of the brain has been stroked out, so that means it becomes dead. Then it will increase the pressure inside the skull, and then that patient requires an emergency surgery to decompress the skull to reduce the risk of mortality or the death of the patient. So followed by the surgery, then yes, again the role of a surgeon under a tertiary care center or a quaternary care center gets limited to the acute care for the first 1 week or 10 days. So followed which, then the rehab centers or the aggressive physiotherapy, which will prevent the patients to sustain the lung infections or to increase his weakness, whatever he has developed due to the stroke, that can be improved because of the physiotherapies and rehabilitation centers.
Yeah, so this was like more of a post-operative rehabilitation that we are talking about.
Yes.
Is there a role of pre-operative, having a comprehensive module as a pre-operative rehabilitation module for cases like this, where it is where the surgery is planned? I mean, obviously a stroke patient is an unanticipated event, but where we have anticipated surgeries, elective surgeries happening, and can we come up with a comprehensive module? Do you think it plays any role?
So there are certain indications where we can start the physiotherapy and exercise pattern prior to the surgery, something like in a patient with a critical canal stenosis in the cervical spine, where the patient is already quadriplegic, which means weakness in all the 4 limbs, both hands and then both legs, and then he will have difficulty in breathing also. His breathing pattern will alter. It will become very shallow and rapid breathing will be there. So if we start the physiotherapy for this kind of patients, but not, yes, we have to keep in mind that the patient has very narrowed spinal canal in the neck. That should not be twisted or these things. Just a gentle physiotherapy for the hands, and then spirometries to expand his lungs properly. And then, yes, the quadriceps strengthening exercises and then core muscle strengthening exercises just a week or 2 weeks before the surgery, if the patient gets identified early. And then post-surgery, if it is continued, then the improvement for the patient from the point of patient, it will be much better and then very good.
So in your opinion, how much of an improvement happens in a person getting good physiotherapy versus, just a regular at-home care post surgery?
Okay, percentage point of view, I may not be able to comment because till now I haven't seen any patient who underwent physiotherapy and then came for the surgery. So any patient whom we see in the OPD or in the emergency with a weakness of all 4 limbs, then straight away we will admit the patient and then we will advise for the admission and then surgery as early as possible, followed by the physiotherapy.
Okay. What about post-op? Is there, would you be able to give, what in your opinion would really, is there a difference between getting good physiotherapy in a center like Sukino versus, just having regular care at home in a post-operative scenario?
Yeah, post-operative scenario, yes, at home, definitely there will be some lacunas, and rehab centers will have a step up for the physiotherapy. So because all the physiotherapists will be available round the clock in the rehab centers like Sukino, which is well established now in pan-India wise also. So they have something like almost like a hospital setup, except for the ventilator and an ICU setup. So here the physiotherapist, respiratory therapist, swallowing therapist, everybody will be available round the clock as needed. And then even on the public holidays also, the patients can get the physiotherapy. So which cannot be given probably at home. So even at home, if the patient is taken by the family members will not be able to do all the therapies needed for the patient. So if a stroke patient should be treated separately and a spine surgical patient should be treated separately. So both cannot be mixed. So this difference will definitely play a major role in the rehab centers.
So I'm sure our viewers would like to know any success stories or stories that have inspired you from your own personal experience as a neurosurgeon. Anything that comes to mind?
Yeah, so I have of late recently we operated quite a few emergencies where some emergencies has been stuck deep to my brain and then to my heart. So where of which a couple of stories I can tell. So a 34-year-old gentleman was brought to our emergency post-COVID vaccination, not vaccination, so post-COVID recovery. A month later, COVID infection, he was brought to the hospital with a sudden onset of giddiness and weakness of all the 4 limbs. So when we evaluated him, we found out to have a stroke in the small brain, so which is called as cerebellum, and on the left side. So he is 34-year-old, a software engineer, and relatively he is young, so he has still a lot of life to survive, and then he has a family, a small child. So we offered him for a surgery. Yes, we operated him on a Sunday, which I remember still, and we took up as an emergency surgery around noon, 2:30, and then we finished by 4:30, 5 o'clock. And then next day patient woke up very good, and when we extubated him, we removed the ventilator connections after a couple of days, and then the patient was shifted to the regular ward. He improved. So, and then post surgery from the hospital, when the acute care has been finished from our point of view, then we suggested for the rehab center in the Sukino. So they came here, they got also satisfied here, and then they brought the patient here. So in Sukino, after the rehabilitation, so recently he came back for the follow-up and then a repeat MRI to see how the structures are going on inside. So I was surprised to see how the patient improved so much that his imbalance, very mild, he has a very mild imbalance while walking. Rest of the things he has been improved significantly. He is walking independently. He's doing all his activities. So which may not happen in this short duration without the rehabilitation centers. And the second success story is a 92-year-old gentleman from my hometown itself. And entire family got shifted to US and settled there. So he came for a wedding where he has giddiness and then fall. From the wedding hall, he was rushed to the emergency where we found out to have a bleed in the cerebellum, which is a small brain. So we took him up for surgery again, and then yes, recently they came for the follow-up, almost a similar stance. So he also went for the rehabilitation center, and then he also improved. Now he is walking independently. Now probably a smaller tracheostomy tube which is there, that also will come out in the shorter duration. And these two are the stories which I can remember from my heart.
I'm sure the patients are really, really grateful for such a huge leap in their recovery. That's really great. We've all heard about neuronavigation, the latest advances, and all the other things. Can you just put some light on that? What are the latest advances?
Yeah. So the neurosurgery, when compared to past 2 decades or 3 decades before, there are a lot of advances which we had now. So among them, the major advances which were being used all over the world and even in the 40s. So on par with the world advancement, we are also using all the latest technology, something like neuronavigation. So neuronavigation, and then a special dye for the tumor surgeries which is called fluorescein, and then a nerve monitoring, and then awake surgeries. So these are the 4 things which are being done regularly in 40s for almost every patient as needed. Some patients will need some patients will need the other thing. So the neuronavigation is something like a GPS in our car or in a cell phone, so which will direct from our location to the destination. So similarly, we can localize the tumor in the brain with the neuronavigation, specially designed MRI, so which will be converted into a CD format, and then it will be transferred into the system which we use in the OT to localize the borders of the tumor from the surface of the skin itself before starting the surgery. So once we use the neuronavigation, mark the tumor borders, then it will be easier for us to navigate through the brain tissue, minimizing the damage to the normal brain parenchyma, and then excise the tumor as much as possible safely. That is the number one. And number two is awake surgeries. So whatever the neuronavigation we use, so it has its own effects. I mean, it has its own limitations. So something like if the tumor is on the left side, if the patient is completely under anesthesia, then we may not be able to know whether he has any speech disturbances or any weakness he is developing in the right side, because when we operate on the left side, the brain controls the right half of the body. So if the tumor is on the left side, where the speech centers and the right half of the control systems will be located, that part, if the patient is well educated and very brave, we will counsel them for an awake surgery, where the patient will be awake throughout the surgery, from the skin incision and then skin closure, where the patient will be awake speaking with our anesthesiologist, and then we'll be operating continuously, and then we'll remove the tumor. If the patient develops anything, any change in his mentation or any weakness or any speech disturbances during the surgery, he will convey the same, and it can be picked up as early as possible immediately, and then the surgery can be stopped or hold back.
Yeah.
So that is one thing. And the third thing which I can tell is about the nerve monitoring. So usually in majority of the surgeries, apart from the neurosurgery, rest of the surgical branches, they will use the complete anesthesia, where the patient will be put into sleep and connect to the ventilator, and then they will operate. The patient will come out of the anesthetic drugs. Now here the nerve monitoring, if we give the complete anesthesia, the nerve monitoring cannot be utilized. So where we use the special anesthetic drugs, which our anesthesiologists are well aware, and then they are very experienced in this, so which we call as TIVA, total intravenous anesthesia. So the anesthetic drugs will be on continuous flow, and there will not be muscle relaxation, will not be there. Patient will be in a deeper plane of anesthesia, and then patient will not feel the pain. But yes, when we stimulate the nerve, when we are operating, especially in the spinal cord, where the spinal cord tumors or contractures of the spinal cord in the newborns or infants, children, if we are operating. So the spinal cord, if it is attached in the lower segment, to detach it, or this kind of surgeries, or the spinal tumors which arises from the substance of the spinal cord. So these kind of surgeries, we use the nerve monitoring. So where we can stimulate the spinal cord, and sensing the tumor, where the tumor can be identified, and the spinal cord and the spinal roots, that also can be identified. If we stimulate the spinal cord, yes, we will get a stimulation in the monitors, where that can be monitored by the neurophysiologists. So they will also be helping us in the OT during the surgeries. So if the nerve monitoring is not there, so anything can be cut off, anything can be sacrificed, and then post-operatively patient can have the deficits. So the deficit can be minimized, or no deficit we can achieve.
No, this is exciting times, and I think a lot of exciting stuff to come ahead also. And I think these things work towards minimal damage, faster recovery, having a lot of precise extraction of the tumor. I think that really the excision of the tumor is very much more precise. So all these things are really exciting. I think I'm sure our viewers are really may not be aware of all of these things. So thank you for that. So what would you like to really tell do you have any suggestions for our viewers, any advices, any recommendations? What is it that you would like to say to our viewers?
Okay, so the first thing, in the past couple of years, everybody's life has been at halt because of the unfortunate pandemic which we are facing and struggling still. Yes, wear the mask properly in the crowded places. That's the first thing which I can tell. And then be a responsible citizen, take the vaccine at your turn, and then get your vaccination completed. And the second and the third thing which I can tell, because as of late I am seeing more of younger generation with lot of spine issues, where they are used to be in the sedentary lifestyle and the sedentary mode of life. and then poor ergonomics while working from home, basically. So the proper ergonomics when they are sitting or working, and don't carry the laptops onto the bed and sofas. This is the foremost thing. And then keep yourself active throughout the day, and then don't sit more than half an hour, 45 minutes at a stretch. Keep yourself walking at least a couple of hours a day, and then cycling, swimming, whatever habits. So in fact, I do a lot of physical activities. Mornings I will go for a walk, and then evenings I will play 1 hour of intense badminton, and in between I will go for a cycling also. So probably I would like to keep myself fit for a longer still my career ahead. So let's see how the things will go, and I hope all the viewers who are here, who are watching us, can stimulate and themselves, and then they can get back into the groove.
That was very good advice, and I hope and wish that the viewers will follow whatever you have recommended. Thank you so much. So viewers, this wraps up the health capsule for this week. Thank you, Dr. Reddy, sparing your valuable time, being here with us, giving us wonderful insights, and we'll catch you next time. Thank you so much. Bye-bye.
Thank you. Bye-bye.